Okay, in this chapter, chapter 47, we'll be looking at processing and testing both urine and stool specimens. Okay, so the things we'll be looking at are just discussing the role that medical assistants have in collecting, processing, and testing both urine and stool samples. We'll talk about some of the guidelines that are important to follow when collecting certain types of urine specimens. There's 5 different specimens, and we'll talk about those as we go in. We'll talk about what the process of a urinalysis is and what its purpose is and what some of the disease processes that can be detected from a urinalysis. And then we'll talk about some of the proper procedures for collecting and processing stool samples as well, for fecal occult blood testing, as well as for bacteria and parasitic and protozoan infections as well. Okay, so it's really important. There are certain proper collection techniques that are important with both urine and stool, so making sure that you're familiar with each one of these, it's very important because otherwise it can affect the exam or testing outcome, okay? So it's important to learn about what each of them is for and what they're used to detect, be able to instruct patients accurately and correctly on the proper collection process, and we will kind of go through some of the constituents or the that are involved in urine samples, and so it will be important to have an idea of those constituents. And then we will also do a little brief discussion on something called the chain of custody for drug testing. Okay, and so as you go through, the urine is actually a very inexpensive test, and I had a few clinicians and PAs through the years that have told me, there's certain tests that are very inexpensive, so don't ever hesitate to do it, to check, because you can get a lot of information from certain tests, and some things really aren't that expensive. Pregnancy testing, urinalysis, hemoglobins, and those kinds of things, blood sugar, glucose, are very inexpensive and easy to do. And so urine is one of those that's very simple, but it actually gives you a lot of information about that individual and that individual's health. And the knowledge that's important is to have a pretty good working knowledge of the anatomy and physiology of the kidneys, which is why you guys are going through chapter 30. We need to kind of refresh on how urine is formed and why, and then the different components of urine that are actually considered normal versus components that maybe aren't normal. Okay, and so it is considered potentially hazardous. Okay, so generally things that are associated with doing the urinalysis will generally be disposed of in the biohazard. Okay, now urine doesn't necessarily have a lot of bacteria or contaminant with it, but it is still considered potentially hazardous waste. So we always want to utilize standard precautions, washing our hands, putting on our gloves before we touch any urine specimen, even if the urine's not going to touch us. So the appropriate PPE as needed. Sometimes goggles might be necessary depending on the situation. We have to make sure that we handle and dispose of all of the specimens properly. And like I said, we're prototypically going to put the containers in the biohazard. However, urine is oftentimes disposed of. When you're done with it, it can be disposed of down the sink. And so that is something that that's actually where you put the urine when you're done, if you don't need all of the specimen that's been left. So we want to make sure we dispose of all the supplies and equipment properly. Most of the stuff that we're going to utilize is going to be disposable, but you would want to sanitize, disinfect, and or sterilize things that are considered reusable. For the most part, we're not going to be dealing with things that are reusable in this particular case. All right, so what does a medical assistant need to know related to collecting, processing, and testing urine specimens? We need a good working knowledge of anatomy and physiology. We need to know how and why urine is formed, and then we need to know what is normal and abnormal as far as components of the urine go. Okay, so some things to follow. We're going to talk about some different urine tests, and so there are 5 different ones that the book discusses. It's going to be important to know which one you're performing, and you're also going to need to know the proper instructions to give the patient, okay? We always need to make sure that we appropriately label each specimen. We always label the jar itself. We never label the top or the cap, okay? So that labeled specimen will usually have a sticker that's got first and last name, date of birth, medical record number, doctor, and oftentimes time that it is collected, okay? And so it's important to know which procedure you're doing so you can explain it to the patient. Once again, we wash our hands before and after. We always wear gloves, and then we always complete the paperwork appropriately, whatever requisition form is needed. A couple of other things too. Some things, we have to make sure we use the correct container. Some of these can use the same container. Other things need a specific container. So once again, we need to know what we're doing so that we can give the appropriate container. Some of these containers will have a powdered or a liquid preservative within the container in order to preserve the urine for the time frame until the test is done. And so you always want to let the patient know that if that particular container comes with a preservative, not to dispose of it, okay? When you're doing these tests, you can refrigerate the collection container in between to prevent the growth of bacteria and until you can actually get it to the lab, okay? And we're always going to keep the lid on the container as much as possible. Okay, so here's two words that we've seen before, quantitative and qualitative. So when we're going to talk about this a few times as we go through the next couple of weeks. Remember, quantitative is looking at how much of a specific analysis. Qualitative is generally looking for the quality or just the presence. So a lot of times a qualitative analysis is either a positive or a negative or a yes, it's there, or a no, it's not, okay? Quantity refers to if it's there, how much is there, okay? And so when we're looking at different specimens, we want to make sure, once again, that we collect our specimen appropriately and make sure we educate the patient on the time frame in which to collect that specimen, okay? Procedure following is very important with these. Okay, so let's talk about the 5 different kinds of urine specimens that we can obtain. The first and most commonly ordered urine specimen is called a random urine specimen. It is the most common in primary care as far as being ordered. It can be obtained at any given time of the day. You don't need to use the little wipes to clean yourself, whether you're male or female. Commonly, these are pregnancy tests. They're also commonly called dirty urines because you're not cleaning yourself. And so doing sexually transmitted infection screening for gonorrhea and chlamydia can be done off of a random specimen at any given time of the day, and you don't have to clean yourself for that, okay? Then we have something called a first morning specimen. So this is a specimen that's generally collected after waking up in the morning. The reason why we might do that is because certain substrates and certain substances are at greater concentration in the morning. So this isn't done all the time, but there may be certain things, certain electrolytes or certain things that a doctor's looking for that might give more diagnostic information if it's collected first thing in the morning. So these aren't ordered all the time, but it's important. Questions that are important relating this are if you have a male or female that perhaps has nocturia or incontinence where maybe they're losing their urine or they're maybe urinating 2 or 3 times at night. So that might decrease the concentration of substances in there. So it would be important to ask those questions if they have incontinence issues or how many times they get up and go to the bathroom normally at night. Some people sleep all night. Other people might have to wake up once or twice, and so that can be an important piece of information to include to the clinician because that can affect the outcome of the test. Then our third type of urine specimen is called a clean catch midstream. So this is a particular urine which we're which is used in order to detect whether or not someone has a urine infection. Okay. And so important things with a clean catch midstream is, number one, this once again is used for culturing. These are when they'll usually give the patient some little cleaning pads that must be used in order to cleanse the external genitalia to make sure that we don't have skin contaminants from the outside of the vaginal or outside of the penile, basically any skin contamination. And so we'll go through and discuss this in class, but generally you will urinate just a little bit in the toilet and then stop. And then the individual will clean themselves in a specific fashion, and then they'll put the rest of the specimen in the bottle. Okay, and this is once again important. If the person doesn't use the cleansing pads, then it could have a lot of contamination. It may be difficult to get an accurate culture. Okay, so being able to describe this to the patients is important because they need to realize how important the cleansing process is. Okay. Then we have a couple of different time tests. Now, time tests are usually used in order to detect certain substrates, calcium, potassium, creatinine, and there are different kinds of time tests. There are 2-hour time tests, there are 6 hours, there's 12 hours, and so you have a different time frame where you actually have to collect urine in that time, in that specified time frame. If you send somebody home with a timed urine specimen, it is okay for them to put the samples in a large container in the refrigerator with the cap on because you want to prevent any bacterial growth from occurring. Okay. And then we have a specific 24-hour specimen. This is still a timed urine specimen, but the 24-hour specimen is probably the most common of the time frames, and we use this to detect when someone has proteinuria during pregnancy or during diabetes, or if they want to do a creatinine clearance, they'll sometimes use a 24-hour urine specimen where they start at 7 o'clock in the morning, let's say, and then they will continue to gather the entire amount of urine that they output in a 24-hour time period. So it's also important with timed urine tests to make sure that whatever time they decide to start, that they empty their bladder at that time frame, and then that's where the time would begin. If they're going to do a 24-hour specimen and they're going to start at 7 o'clock in the morning, they would empty their bladder into the toilet, and then that would be their start time. And then anything in that 24-hour period until 7 o'clock the next morning would be collected, including 7 o'clock the following day in the morning. That would be the last specimen, and that would be your full 24-hour specimen. You're always going to start with emptying your bladder first into the toilet, and then that will be your start time. Okay. Those 24-hour specimens usually come with a little bit of powder or liquid preservative in it, so it'd be very important to make sure that the patients know that that's normal and to not discard it. There's also case scenarios where we have to catheterize, and catheterize is a procedure where we actually put some sort of instrument inside the bladder that actually allows urine to be obtained in a sterile fashion. Okay, and so this is considered a bit of a invasive procedure because if there's bacteria on the outside of the skin, you can, taking this tube and inserting it into the bladder, you can literally create an infection. And so this has to be done in a sterile fashion with sterile equipment, and iodine is usually used to cleanse the external urinary meatus. Medical assistants don't prototypically do catheterizations in most states, but it is possible that you might set up and or assist, and so being familiar with the procedure is important. The procedure that's shown here, you can see the bladder looks like an upside down triangle. But remember, it's got transitional epithelium. It's very stretchy. It's like an bamboo bag, and it can hold up to 2 liters of urine, but I don't recommend trying that. And you can see that the particular catheter that they're using here is a flexible rubber catheter. It's called a Foley catheter, where you actually have 2 tubes. One tube goes inside the bladder, goes up through the urethra into the bladder, and then you can see there's a little small balloon that's inflated with the other tube that's adjacent to it that allows the catheter to stay in place. So if people are hospitalized, or if they can't urinate, or if they're having surgery, this is a way that you can actually put a catheter inside and you can collect all of the urine, and that way you can assess sort of what they call input and output. You always want to make sure that to assess kidney function, they will collect urine. They'll use this indwelling catheter that allows urine to be collected so that they can do an input output and make sure that kidney function is appropriate and working correctly. Okay, so this is a Foley catheter. And so some reasons where you might use a catheter would be to relieve urinary retention. There are some times in certain disease processes where people cannot completely empty the bladder, and so people struggle with that. Sometimes people with multiple sclerosis cannot, because the nerve endings are not working correctly. They sometimes can't completely release all of the urine in their bladder, or if they have a stricture or narrowing of the urethra. So there are reasons why people might have to catheterize themselves. If you need to obtain a sterile urine specimen, as much as you might clean externally with a midstream catch, or it's still very difficult to get it sterile. So this is a way that you can obtain a sterile urine specimen. Certain disease processes can be diagnosed as well by checking the amount of residual urine. So if somebody's got an excessive residual urine volume, it might help to diagnose certain bladder and or kidney issues. If someone has a bladder spasm, which actually happens, or a narrowing of the urethra, and they actually can't go to the bathroom, you can actually insert this tube, and that can help relieve urination if a person can't actually go to the bathroom. We can instill chemotherapy if somebody has bladder cancer. You can do certain, there's something called a straight cath, where you can insert a catheter that actually allows you to instill some sort of chemotherapy. And then obviously if we need to empty a bladder either before, during, or after a procedure, it can be done for that too. There's a number of different kind of drainage catheters. The most common that you'll see in primary care would be the indwelling or the Foley catheter that we saw with the first picture. If you're going to instill chemotherapy, or you just need to do a quick drainage of the bladder for a quick reason, you can use a straight catheter. The other ones, the ureteral and retention, and some of the others are more to do with catheters via ureter if somebody's had kidney or ureter surgery. But the indwelling, which is Foley, and the straight catheter are probably the more common in primary care. Once again, catheterization can actually pose risk of infection to the patient, so it isn't considered a routine procedure. Once again, medical assistants don't generally do this, but you might set up and you might assist, so it would be important to at least be familiar with the procedure. Some things to look at too when you're looking at urinalysis with male and female patients. There can be differences in collecting a clean catch midstream specimen. Generally, when you have a female, they're going to clean on both edges, and then they're going to clean. You're going to give them 3 wipes. They'll clean on one edge with 1 wipe. They'll clean on the other edge with another wipe, and then down the middle with a 3rd. You have to do the same thing with males as well, but knowing whether or not they're having any incontinence or any nocturia is important questions to ask. So knowing your patient's prior history and or age is important as far as getting those questions. Pregnant patients can be a little bit different. They tend to have something called urinary frequency. Because the uterus is getting bigger, it puts pressure on the bladder. So a lot of them will report frequency, which is increase in urination time frame, but not necessarily more urine per day. But they do tend to feel like they have to go to the bathroom more frequently. They usually have to get up at night to go to the bathroom. Because the bladder is underneath the uterus and the uterus is getting bigger, it does tend to make pregnant patients more prone to urinary tract infections. So we tend to treat a little bit, or at least check and do analysis for bladder infections more frequently when they're pregnant. And urine checks need to be done every time, not to repeat the pregnancy test each time, but to check for glucose and protein, and we'll talk about that a little bit later. Now there's something else called establishing a chain of custody. And so chain of custody is a specific process in which we have an entity, whether it is a job or the courts, that are claiming the need of a drug screen or background check. Okay, and so we have something called chain of custody, where we have a certain process that has to be dealt with the urine that's being obtained, and that a specific form has to be signed in order to give the facility that's ordering it permission to have the results. Okay, and so following the procedure to the letter of the law is very important. Okay, and so there is certain procedures that have to be explained to the patient, and you have to get a consent form signed in order to do the test, as well as to provide permission to the facility that's requesting it. Okay, so some of the procedural rules are a little bit different with a chain of custody versus other urine tests. Number one, the person generally cannot take a purse or a jacket or anything into the bathroom with them. They usually have lockers set up where the patient will put phone, keys, everything that they have except themselves can go into the bathroom. It's usually timed as well. They usually give you 4 to 5 minutes maximum to obtain the urine. You're not allowed to wash your hands before or after. They usually have a separate sink where you wash your hands. Frequently there's no running water in the bathroom. The other thing is they don't have you flush the toilet. Sometimes they put a blue coloration in the water of the toilet to make sure that somebody doesn't try to use toilet water or free-flowing water to affect whatever urine they have. Sometimes if somebody is using some sort of drug, they don't want someone to find out about it, so they'll do sneaky measures to try to get away with it. And so that's why you're not allowed to take anything in. There's been people that have tried to bring in other people's urine and use that as opposed to their own. So that's why there's a certain established set of protocols that have to be followed when obtaining these urines. Okay, so preservation and storage. Urine things can happen to the urine if it's left out for too long. And so prototypically, if you're going to do urinalysis studies, it's good to make sure that you do it within the first hour. If it's going to be longer than that because the day is busy and there's lots of patients leaving urine specimens, then you can stick the urine in the refrigerator. Okay. The refrigeration can prevent growth of bacteria for 24 hours, but you start getting longer than that, and bacteria can start to grow that maybe aren't pathogenic. Okay, so the time frame here that we need to look at is that if you're going to do your analysis, if it's more than an hour, put it in the refrigerator. If you can get everything done within an hour, that's fine. You're not generally going to hold urines overnight. Most of the time they're going to do the analysis, that if they need to send it off for culture, they will prepare that, and then things will get sent off within the day's time frame. If you do put it in the refrigerator, it's important to make sure you let it return to room temperature before you start doing your test analysis. And it is normal that the longer the urine stands, sometimes the cloudier and the more crystallite stuff that you'll actually see form. And so sometimes the characteristic of the urine will change a little bit the older it gets or the longer it's in the refrigerator. Okay, true or false? A random urine can be collected at any time. Random means any time, so that is true. A clean catch midstream urine specimen should be collected first thing in the morning. Okay, well, we talked about that. Clean catch is when we are doing the wipies and when we're checking for an infection. The first thing in the morning would be a first morning urine specimen. You would instruct the patient to discard the first specimen when collecting a timed or 24-hour urine specimen. That is true. We would urinate and then do our time start, and so that would be the starting of the time frame. But you always discard the first one and then start your time. A chain of custody form gives you permission to release the results to the agency requesting the test, and that is true. And then urine specimens should be refrigerated if they will not be tested within 4 hours, and we just kind of discussed that. Anything more than an hour, you need to put it in the refrigerator and then allow it to come back to room temperature before you start checking it. Okay, so now we're going to look at the urinalysis. And so when we actually look at urine, it's a really good way to evaluate the actual overall health and disease process. It doesn't necessarily mean that if your urine is completely normal that there couldn't be a disease process going, but a lot of things can be determined by looking at a urinalysis. And so 3 things that we look at when looking at a urine: we do a physical inspection of the urine, we do a chemical analysis of the urine, and then we can do a microscopic evaluation of the urine as well. All right, and so when we look at these values, when we're doing the chemical analysis of the urine, there's different values that we can look at. And so some things are going to report it as negative or none, meaning it's not there. Other things might be considered normal. And then there's a few other things that might be given in a range of concentration. So we'll go through each one of the pads and kind of show which ones are negative or none, which ones are normal, and then which few have a range that are a range of concentration that are considered normal. If you have a completely normal urine, then that would indicate, at least health-wise, everything is normal with that particular individual. Okay. So we're looking at output of urine. Prototypically, your input and your output should be pretty close to being the same. It may not be exact, because if you're dehydrated, you're out and it's really, really hot, then you might actually intake more than you're outputting because you're going to lose a lot in sweat. But prototypically, your input and your output should be relatively close to the same. This 1250 milliliters per 24 hours is kind of an average. Anywhere between about 1,000 milliliters and 1,800 is kind of considered normal, so they just kind of come up with an average of 1,250. If we're going to narrow that to a range, probably 1,100 to about 1,300 is normal, depending on the water intake and liquid intake of that individual. Okay. And there are some things that can be determined. There can be some disease processes that can be determined and detected by doing just a regular normal urinalysis, and we'll talk about a few of those. Okay, so you always want to make sure labeling, we're always going to label the bottle and not the lid, okay? Always make sure you check for visible contamination, and it's a good idea to check the time since collection. So you're always going to want to put a time frame once that urine has been collected so you know what you're dealing with time-wise, okay? The first thing we're going to do is a physical or a visual examination of the urine. We're going to look at color and turbidity. We can look at the volume, which is the amount. Odor is something we don't necessarily report, but it can be something that we notice. And then we'll also talk about something called specific gravity, which is actually the amount of concentration of solutes within the urine. So when we look at the first thing, we can look at color. Okay, the first inspection that we do is we look and go, okay, let's check our color. And the color will vary depending on how much you drink, how much water you drink. So it could be very, very light or pale yellow all the way to kind of a dark amber. And obviously the more water you drink, the lighter it is. And the less water you drink, the darker it can be. And so that can kind of indicate the concentration of solutes if it's more dark versus whether it's light, okay? So that's the first thing that we look at. Second thing we look at is the urine kind of clear or is it cloudy? And so usually it's a clearish color, but if there is a cloudiness to it, the other word for that we use is turbid or turbidity. And so if it's very, very turbid or cloudy, then that can indicate oftentimes an infection or some other issue going on with the kidneys or the bladder. And then we can look at the volume. Now volume can be, the volume that they're giving here is just sort of the average urine output in a 24-hour period. You're not really going to evaluate that on the urine samples that we're doing. But normal, they say here, is 16 to 1800, with the average being somewhere between 11 and 1200 per day. Terms that are listed there are oliguria and anuria. So oliguria is usually under 2 to 300 milliliters per 24 hours, which means scanty. There's a little bit of urine output, but it's scanty. Anuria means pretty much either very, very minimal or lack completely of, and so that's usually under 100 milliliters per 24 hours. So knowing those two terms are important. There can be a normal odor that comes with urine, and so it can be a little aromatic. It shouldn't be pungent or really, really strong. We don't typically record it, but sometimes people will present with saying that their urine odor has changed. So sometimes a malodorous urine can indicate an infection, although we don't prototypically report this anywhere on our requisition sheet that we're writing on. Okay. So the other thing that was mentioned there was urine specific gravity. So specific gravity is actually a measure of the solutes within the urine. And so when we look at water or distilled water has a specific gravity of 1.000 because there are solutes like hydrogen and sodium and potassium and some other things. There does tend to be solutes in there. So the specific gravity will generally be higher in urine than water. Okay. So the normal runs anywhere between 1.005 all the way up to 1.030. I know the numbers are a little different there, but those numbers are not listed on our pads. We actually, instead of using a refractometer now, which is what this is a picture of, we don't really use this because we actually have a pad, a reagent pad, on our dipstick, on the reagent strips that actually gives us the specific gravity. So although a long time ago they used the refractometers, we don't need to do that. And so once again, fluid intake will affect this reading. High specific gravity is 1.020, 1.030, somewhere in that range, can sometimes indicate an infection, but it can also indicate lack of water, dehydration, or fever. Anytime you have high specific gravity, that can tend to be a reason why. Okay, so those are some of the things to look at before we get started. The picture here shows a typical looking reagent strip testing for urine, the bottle that it looks like. You can see all the little colored pads on the side. That's basically what we'll be doing in class, is dipping those and taking a look, and we'll talk about what each pad is and why it's important. Okay, and so you'll note after dipping that pad into the urine that some of the color schemes will change. And so different color schemes will give us an idea of some of the different chemicals that may or may not be, or different solutes or different substrates that may actually be in the urine or not present in the urine. So following the instructions carefully and closely is important. A couple of things about the bottle that are important. Always keep the bottle tightly closed. We don't open the bottle until we're ready to pull the strip out, okay? And we need to make sure that all of our stuff is ready to go and that we're ready to dip it before we pull it out. We don't ever leave the bottle lid off and continue doing our work. You always open it at the last minute, pull out the strip, and then recap it tightly, okay? Prototypically, you will date it when you open it. You always want to check and make sure you haven't passed your expiration date. And then generally they'll discard it after 6 months. Check with the facility that you work at, but that pretty much tends to be a pretty common procedure, is to make sure that they get rid of them after 6 months. Okay. There are colored pads on each strip, and you want to make sure that you don't touch or rub those pads. Okay. And it will be analyzing the color changes that will give us our reading of our dipstick. Okay. So we're going to go through a few of the pads that are located on that dipstick. One of the first ones that you'll see is called a ketone body. Ketone bodies actually are normally there's none in urine. Okay. But if there's case scenarios where someone starts to burn fat as opposed to glucose, that will cause ketone bodies to form. They tend to be acidic, and so it does tend to make the urine and the as well as the blood acidic. Things that can cause that to happen are some form of dehydration, fever, vomiting, and if someone has uncontrolled diabetes, they will have a lot of ketones in their urine as well. So prototypically you have none, but there are some disease processes that can cause those to occur. We also take a look at the pH. Now remember, pH stands for potentiation of hydrogen ions. And so when we do this, we're measuring the either acidity or alkalinity of the urine. Prototypically 7 is normal, that's water. And so our range can vary depending on what we eat and what we have going on in our system. And so anywhere between 5 and 8. So there is kind of a big window there. 5 to 7 would be an acidic urine. 7 to 8 would be a more alkaline urine. And so when we talk about urinary sediment and crystals, certain crystals tend to form in acidic urine. Other crystals are a little bit more common in alkalinic urine, and we'll hit that when we get to the end. Another reagent pad on the strip is for blood. Remember, the term for blood is called hematuria. So the thing about blood is this particular pad's actually pretty sensitive. It can pick up even very, very, very small, minute amounts of blood. And the thing is, it's very non-specific, okay? And so if someone is on their period and they leave a urine specimen, a lot of times this thing will turn color big time. And so it doesn't discern between where the blood's coming from, but it could be, you know, if someone's got a cystitis or a urinary infection, or if they've got something going on in the kidney, or even a kidney stone will cause hematuria. And so it can be utilized to detect some disease processes, but once again, it's not specific. It doesn't tell you exactly what the blood is, it just lets you know whether it's there or not. And it tends to, once again, be very sensitive. Then we have two other pads. One is called a bilirubin pad, and another one is called urobilinogen. Bilirubin occurs from the breakdown of hemoglobin. When you start seeing elevated levels of bilirubinuria, or that pad lights up, sometimes it can be it's generally from the breakdown of hemoglobin. It can be a sign of liver disease. And so that's why some of these pads you might have to do further testing, but it can alert a clinician that there might be something going on, and then cause the clinician to do some more lab tests to figure out what's going on. Urobilinogen tends to be elevated when you have some sort of hemolytic situation where you have increased red blood cell destruction. If you're lacking it, it could be indicative that there's some sort of bile duct obstruction. So these two are a little bit more specific for liver issues and or hemolysis issues. So we don't often make specific diagnoses off just these, but it would kind of indicate that maybe we need to do some more testing of the liver and some other avenues if these are abnormal. Next two are glucose and protein. Now there is a special small dipstick that's used in obstetrics that has just these two pads on it for glucose and protein. They're also present on the longer 10 reagent strip dipstick. But when we look at glucose, obviously if they're, small amounts, especially after drinking a soda or eating a candy bar, can be normal, but having larger ranges or higher amounts of sugar can indicate that someone is diabetic. And so that's why glucose is one of the dip pads on the short dipstick for pregnant patients, because it can sometimes let us know whether or not that patient has gestational diabetes. Protein is also there. Now, normally the kidneys can excrete just a little bit of protein. So just a hair or trace of protein isn't necessarily abnormal. But when you have excessive amounts, it can indicate that there is stress on the kidneys or renal disease. And so proteinuria is the case where you actually have a significant amount of protein in the urine. And that's why this particular dip pad is there. Oftentimes, if this is positive, they will then do a 24-hour urine protein, depending on what the person's underlying medical conditions are. Proteinuria in a pregnant patient can indicate that that patient is having stress on the kidneys and is maybe a risk for toxemia. So these two are very important. Once again, there's a special small dip or a small dipstick that has just this for pregnant patients, but these two are also located on the bigger strip pad as well. Now, these last two that are listed here, nitrite and leukocytes, let's go with leukocytes first. Leukocytes, if you remember from medical terminology, means white blood cell. So generally, if you've got leukocytes within the urine, that generally indicates that there's a possibility there's either a urinary tract or possibly a kidney infection. Sometimes skin contaminant can lead to this. If someone had a sexually transmitted infection, it is possible that some of those leukocytes could creep into the urine and show themselves in the urine, but it generally can indicate that there's some sort of infection either in the urinary tract or the genital tract. And then we have something called a nitrite. And a nitrite is a byproduct of bacterial invasion or infection. So we only see nitrites if bacteria have actually colonized within the urinary bladder. And so nitrite is what we call pathognomonic or indicative of an infection. So if somebody's got nitrites and leukocytes, they almost inevitably are given antibiotics, and then a culture is sent to make sure that the appropriate antibiotic has been given. Okay, we don't see nitrites unless there's bacterial infection. And the last one that's listed here, phenylketonuria or phenylketones. This is a urine test, but this is not a pad on the dipstick. They include it here because it can be done as a urine test, but prototypically this is a blood test that is performed routinely on newborns within 24 hours of birth or before they leave the hospital. Phenylketonuria is a genetic disorder in which that patient or that child cannot metabolize phenylalanine, which is a specific amino acid that makes up protein. It is something that it's rare, but it is a blood test that's done on every infant born in the United States, and it can be controlled by just making sure that that individual does not eat foods that have phenylalanine in it. But it can be a problematic issue if you have it, because if you eat phenylalanine and it starts to build up in the system, it can lead to mental retardation. So there is a urine test that checks for it. However, we won't be doing that. It's not part of our normal routine urinalysis, and it is not one of the pads on that 10-pad dipstick. Okay. Okay, so that kind of concludes at least the urine dipstick. Let's talk about a couple of other urine tests that we can do that we'll be doing in class, which is pregnancy testing. So this here shows a common type of pregnancy test, okay? You'll see pregnancy tests listed as HCG. That's human chorionic gonadotropin. That's basically the hormone that is secreted from the placenta and the baby when you are pregnant. These are very, very sensitive and can detect a very small minimal amount of HCG hormone in the system, as low as 25 micrograms. There really isn't any benefit to doing a blood test unless you need to monitor the hormone level, because the blood test and the urine test are almost equivalent in what they can detect level-wise. They're very easy to perform and interpret. They are waived tests, and we will be performing these, and you will be doing these very frequently in the clinic. They are considered EIA tests or enzyme immunoassay tests. And once again, they are considered waived tests, okay? So when you look at the two that are listed here, you'll notice that there's a C and a T listed on this test. The C is a control line. Every valid test should have the C line be positive, because that indicates that our test is viable and valid and working properly. The T is short for test, and so you're only going to see the T line if the test is positive. Okay, so in this particular case, the top test has both lines, so there's 2. So the control is there, so it's a good test, and the T line is there, so that's the test line, so that first top test means that we have a positive pregnancy test. The one below has the C line there, which means it's a good valid test, but the T is not present, so that would be a negative test. Okay, most of these require 3 to 5 drops. It will vary depending on the brand that you put in that little chamber, and then they will either be developed or looked at and read in 4 to 5 minutes. And once again, it depends on the brand. Always check your brand and always make sure that you read your test at your time limit and then discard the test after you look. If you let that test sit around for 10, 15, 20 minutes, it's not valid, and sometimes lines will start to, you'll think you're seeing the test line show up, and so it's important to make sure you read the test at their time limit and then record the finding and then dispose of them, okay? And don't let it sit around for 10, 15, 20 minutes. Some other urine tests that we can also do are testing for STDs, okay, or STIs. A new invention, I don't want to say new invention, but it was sort of a revolutionary kind of test that was developed probably maybe 15, 20 years ago, where you could actually do a chlamydia and a gonorrhea test from the urine. And so these urine tests actually detect the nucleic acid of those particular bacteria. And they're very sensitive and they're very specific, so you don't really get false positives. You can sometimes get false negatives, but they're very, very sensitive. Even just one nucleic acid, even if it's dead, can be detected. And so both of these bacteria are common forms of sexually transmitted infections, and so it made it a lot easier to do screening tests. All people wouldn't have to get undressed to do a full exam. They could just leave a urine sample and run the test that way. And so advantages are it's much easier and less invasive, but these tests do tend to be a little bit costly. If someone comes in and is complaining of symptoms, pelvic pain, discharge, cervical pain, or pain with intercourse, or dysuria, it is better and advisable to actually do a full pelvic and or genital urinary exam as opposed to just running for urine tests. It really isn't appropriate to just order urine tests if someone is symptomatic, either male or female. If they're symptomatic and they want to be checked, then they should have a full genital urinary or cervical or urinary swab. But if they are just wanting screening tests because they want to make sure they don't have something, then these urine tests work well. Okay, so once we have our urine analysis, what we then can do after we've done our visual inspection and our reagent dipstick, we can then stick the urine inside a tube, and then we can centrifuge it. And remember, the centrifuge is a machine that spins either blood or urine at a very fast rate. And with urine, what it causes things to do is it actually causes the solute or the solutes within the urine will actually settle at the bottom in an area at the very bottom of the test tube called sediment. And that's what you actually take a look at underneath the microscope, okay? And so there's some common things that we can see looking underneath the microscope at urine. And so I'll kind of drop down. We can, white blood cells and red blood cells, you can sometimes see 1 or 2, maybe 3 per high power field and have that be normal. If you start seeing more than 5 to 10 of either white blood cells or red blood cells underneath the microscope, then that would probably indicate that there's either infection or some sort of inflammation going on within the urinary system, whether it's kidney or bladder or urethra. Epithelial cells, squamous cells are common, but the reason why you do a midstream clean catch is to try to minimize the squamous epithelial cells so that you can actually see whether or not we have any pathogenic bacteria or white blood cells or red blood cells. So squamous cells, you may see a couple, but the more you see, the less of a clean specimen you have. And so we're trying to get as minimal amount of squamous cells as possible. Renal and transitional cells do happen occasionally. Most of the time you're going to see squamous. Transitional cells are actually from the bladder or the urethra. They're the stretchy cells that make up the bladder. Renal cells might be there, but those are from the kidney, and usually you're not going to see those. Then we have something called casts, and casts are sort of protein-filled cylindrical elements. Um, they can indicate that there's some sort of kidney or renal disease going on. Hyaline casts and white blood cell casts can happen normally or in the presence of infection. The other ones are a little bit more ominous for disease processes. Chances are we won't see any of those, but they can indicate some sort of renal or tubular disease within the kidney process. Crystals are a naturally produced solid, okay, of some sort of specific or definite form. And they are very common, and most of the time they're not pathogenic. It's just that if the urine sits long enough, then it can crystallize and cause these specific looking crystals underneath the microscope. The top six are more commonly found crystals within acidic urine. So if the urine is a 5.0 to a 7.0 or 6.99 pH, and then anything above 7 to 8 or 9 would be found with alkaline urine, which are the bottom 5. And so to be honest with you, the most common one that I've seen reported on urines is probably the amorphous phosphates, which is part of the alkaline urine. They're usually not significant for anything major. The calcium oxalate and calcium carbonate ones might occur with people that have kidney stones or have high levels of calcium in their urine. But once again, they aren't necessarily pathognomonic or indicative that there's any specific danger going on in the urine. Other things that you can find in the urine, sometimes are yeast cells. Now, yeast occur when you have some form of infection. It could be even a vaginal infection. They sometimes can look like red blood cells, but honestly, they're more oval shaped, and sometimes they even look kind of like twigs underneath the microscope. You can confuse them with red blood cells, but once you've seen them a few times, you don't usually confuse them with red blood cells. They can be associated with a yeast vaginitis because the discharge can mix in with the urine and you can see that, or if there's any irritation on the outside of the skin. Diabetics are a little bit more frequently predisposed to yeast infections. But I've actually seen male, I had a couple of male patients that left urinalysis and some yeast were seen. And so diabetes is definitely a high risk for seeing that. You prototypically think of it more commonly with females, but when your immune system is suppressed from high sugar levels, it can allow yeast to overgrow. Okay. You can see bacteria underneath the microscope as well. If you have a skin contaminant, oftentimes you'll see a lot of circular bacteria, which are usually staph contamination from the skin. Oftentimes, if you have a lot of those bacteria, you'll also see a lot of the squamous epithelium cells there as well. Pathognomonic or pathogenic bacteria that are more related to infection would usually be rods. Our gram-negative rods from E. coli, Enterobacter that are common within the gut are usually bacillus or kind of rectangular shaped, and so those would be more indicative that you have a bacterial infection that could be, have more of an infection from a specific bacteria as opposed to being a contaminant, okay? And once again, we kind of mentioned odor. Odor can be a little bit more noticeable if somebody has a lot of bacteria and or white blood cells present, okay? But we don't usually mark that on our sheet. There is a parasite that can actually be checked for in the urine called trichomonas. And trichomonas is actually a sexually transmitted infection. You can't really culture it for the most part. You can look at it underneath the microscope, and sometimes that parasite, because it has a tail and is motile or mobile, it can find its way into the urinary tract, and you can actually detect it in the urine of some individuals as well. Men will usually present with dysuria, stinging or burning, and you think, well, maybe they've got a urinary tract infection. And you take a look at their urine and you can actually see this mobile parasite romping around in the urine. Okay, same thing in females. Okay, but prototypically females will have it in their discharge, and then it can secondarily contaminate the urine during a urinalysis. Okay, so here we have what is the specific gravity shown on this refractometer. Now remember, we don't really use this machine anymore. We have our specific gravity pad on our reagent strip, but if you look here, the white part on the bottom, that juncture between the white part and the grayish part is 1.030, so the specific gravity on this would be that particular number, 1.030. And honestly, when we're looking at our reagent pads, the 1.000 to 1.030 is our normal range that we will see on our reagent pads. This does go much, much higher, but generally our pads go to 1.030. Okay, apply your knowledge here. So this is going to actually start with A, B, C, D. It's not going to go down. So A, casts. So let's look at what a cast is. So a cast is a cylinder-shaped sediment of protein. That would be A. Specific gravity is going to be the measure of amount of solutes or the amount of concentration of urine. That's B. Our normal color of urine, remember, is sort of a pale yellow to dark amber. Let's see, C, D. So renal epithelial cells. So those renal epithelial cells could indicate some sort of tubular damage, okay, which is D. Crystals, those are naturally produced solids in cool urine. Most of the time, they don't indicate anything dangerous, although people that have kidney stones will sometimes have a lot of calcium crystals within their urine. Turbidity, remember, is cloudiness. So the other word for turbid, looking at the urine, is cloudy. PKU, that's our phenylketonuria. That's our genetically inherited disorder where we can't metabolize phenylalanine. Usually it's a blood test, but we can do a urine test as well. pH, that is potentiation of hydrogen ions. So that's measuring our acidity or alkalinity of urine. And then the last one, absence of urine, is anuria. So if we have scanty urine, we have oliguria. If we have absence of urine or severe lack of, we have anuria. Okay, so our last couple of slides are going to talk about stool cultures, and we have a couple of different kind of stool specimens that we can do. The first one that we'll talk about is called fecal occult blood test. You'll see it acronymed FOBT. It's also called a stool guaiac test. And so this test checks for hidden blood. In this case, the word occult means hidden. And so it checks for hidden blood that could be that is used as a screening test for colorectal cancer. We do have some more specific tests for colorectal cancer that actually test for the cancer cells within the stool. There's a number of different brands. There's a brand called a FIT test. There's another brand called Cologuard that tends to have a lot of commercials on TV. And those are a little bit more specific for the cancer cells. Those tests cost a little bit more, somewhere between $30 and $50. This particular test is about $10. And so there are still some gastroenterologists and primary care doctors that will use the fecal occult blood test as a screening tool for colorectal cancer. The problem is it's very nonspecific. And so if someone is on their period or has a hemorrhoid, it will test positive. So it doesn't really say, hey, you have colorectal cancer. It just says, well, there is a source of blood. We need to check and make sure it's not cancer. Okay. Because of the fact that it's not as specific, we don't use it as much, but it is cheaper. And so there are still some places that will utilize this if there's an issue with using one of the other methods. So the instruction is important. There are some foods and medications that can cause the test to be falsely positive. If someone is taking aspirin or aspirin derivatives like Advil or Motrin, that can sometimes cause the test to be falsely positive. If someone eats a tremendous amount of red meat, that can also do it. And so usually you'll advise people not to eat red meat or use any aspirin products for 2 to 3 days before starting this test. Okay. And we'll go through and you will all perform your own. You will obtain a stool specimen and you will develop that stool specimen in class, and we will go through all of those instructions when we go through this test in a week. Okay. Then we might have a reason to check the stool for a bacterial infection. And so most viral gastroenteritis or stomach flus are virally related, rotavirus or a few of the other ones that cause it. There are certain cases where people can have food poisoning or some sort of bacterial infection. If an individual presents with fever, and not just loose stools, but bloody and or mucus tinged stools mixed with a fever, there's a little bit more of a risk for bacterial infection. And so we can utilize certain growth culture mediums that can actually isolate either Shigella or Salmonella. Those are the two most common bacterial infections that can affect the bowels. Okay. And so if someone presents with suggestive bacterial infection, they might have to go home with a stool culture to check for these particular bacteria. There's also case scenarios where people can have certain protozoal and or parasitic infections. And so if someone has diarrhea or loose stools or some sort of problem with the intestines, they can also order something called an O&P. And O&P stands for ova and parasite specimen. And so this particular test is specific for protozoans and or parasites, Giardia, amoebiasis, and so there's specific special kits that are available to check for these particular infections. It is usually a different container than you would use to check for bacteria. Okay, you will usually have 6 small jars. 3 of them are fresh and 3 of them are preserved, and so they are a separate container than what would be given to someone that has a suspected or is ruling out a bacterial infection. Okay, some doctors will do what's called shotgunning and just give them everything to check for everything. But protozoal and parasitic infections tend to be a little bit, there's not usually a fever associated. There can be change in the bowels. There's not usually blood, and you're not usually running an infection. And these tend to be a little bit more insidious as opposed to as abrupt as bacterial infections would be. Okay. Last question. Besides how to collect the stool sample for FOBT, fecal occult blood test, or stool guaiac, what else would you need to tell the patient? Okay, and so we'll talk about this. We'll talk about this in class a little bit because I'm going to send you home without instructions, and you guys are going to have to figure it out, and then we'll talk about why it's important for patients to have all of the pre-test instructions. But remember, there are dietary restrictions with red meat, and there are medication restrictions with aspirin and Advil and Motrin and aspirin derivatives. Okay, so that kind of ends this particular chapter. So also go through chapter 30. Computer's doing weird. Make sure that you check chapter 30, and I will see you in the next video.